They want to put it on YouTube.
Okay.
So I'm a YouTuber now.
Yes, you're famous.
Okay. How do I share screen? Okay. I think this is it. Give me a sec. And I'm not trying to pressure anyone, but if you guys want to like switch on your camera, so that I know I'm not talking to a bunch of walls or anyone sleeping, so that'll be fine. I mean, if you guys don't want to like switch on your camera, it's fine as well. Where do I put this? Let me just find something. Code. Hmm. PowerPoint. Intro. Intricacies. Okay, we got this. I'll get it down. Okay. That's one.
Is there anything I can help with?
No, it's fine. I just got it down.
Okay.
So what I'm gonna do right here is I'm gonna share my screen. Okay. Can I share audio? Yeah, share sound. Optimize for video clip. Okay. Uh, now. Okay. Can you guys see what I'm seeing right now?
Yes.
Okay. So as you can tell, like I'm like sharing my screen right now, so I can't really see what's in the comments. So if possible, if there's any comments that they're asking questions, so I really appreciate it if you can like read it out to me because I'm not gonna like scroll back to the comments.
Okay, sure.
Okay, so let's start off. So you guys, this is a session where we're just gonna chill and just talk about stuff I posted on my socials. I mean, that day that when Dahlia approached me to do this, like she mentioned like she would like prefer me to discuss some interesting stuff with you on my page. So yeah, we can do that. And by the way, this is my first time ever doing this, and I just find I just find it funny because like I've never done this. Like it's like random, like a like a medical school in Turkey like just invited me for a medical seminar. So just wild. So yeah, we can start off with this one. I think I posted this yesterday. Yep. Okay, so if anyone's like wheezy or whatever, you guys are not meant for medicine, just straight up. So this is someone who did an exercise which is a reverse I think it's a reverse curl or something where well he's holding like a weight and he's doing a eccentric exercise that targets his hamstrings. So what happened here? Do you guys have audio?
Okay.
Yeah, we're just gonna look at this. Okay. So, I think the audio is clear enough. Can you guys hear the pop?
Yes, it's awful.
Yeah. I mean, you guys hear the pop when his knee gave out, right? Hello?
Did anyone heard it? I did.
Yeah, you did. I mean, as long
Yes,
as
me
you did hear
too.
it, like I think everyone's gonna hear it. So, what happened here is, it's really characteristic of a cruciate ligament tear because like when you what happens is when you sustain injuries to your knee, let's say if it's a meniscus, if it's a tendon, you usually won't hear that pop, that huge sound, the pop that you hear. And that pop, I'm sure you guys have heard of what's a anterior cruciate ligament.
Mm,
anatomy. Okay, we're going back to anatomy. Okay, or flashbacks, everyone. So, can anyone tell me like what structures are attached to the anterior cruciate ligament, inferiorly and superiorly? We're trying to keep this interactive. So if anyone knows the answer, you can just switch on your mic and just tell me, or you can like put it down in the chat, and
I
Dahlia's
think
gonna read out.
the femur and the tibia.
Yep, basically a femur and a tibia. So the ACL is a major stabilizer in the knee. So if your ACL blows out, I mean, it's highly likely that you won't be able to walk like without support. And ACL injuries are really common and sometimes really like career ending for a lot of athletes, you know. I'm pretty sure you guys know, I'm pretty sure you guys are into football, like in Turkey. I mean, I think is Galatasaray is the club in Istanbul?
Yes, it's one of them.
One of them. Okay, so how many clubs are there in Istanbul?
I'm not from Istanbul, so I don't know. Maybe
Uh,
someone else can
okay.
answer.
Is there someone that watches football in Turkey? Can you tell me like what clubs are there in Istanbul? What, none of you watch football?
Ömer actually works. Ömer?
Guys, life is not just about studying medicine.
It's like we're studying at all.
At least do something in your free time. I mean, take a walk sometimes, you know. But yeah, I mean, ACL injuries are really common in football players because of how, you know, it's a contact sport, you know. Like football, you got American football, you got basketball, all these contact sports, yeah, they have a high chance of, you know, knee injuries, especially meniscus, ACLs, PCLs. Okay. So this right here, this clip right here is a very uncommon way of injuring your ACL. Like because like how this exercise is like thought out, it's not really that safe. So if you guys are into the gym and you guys like know about this workout, you guys, yeah, don't do this workout straight up. Okay, so let's just talk about the anatomy of the knee. Okay, so you guys can see this.
Yes.
Yes.
Okay, so what we have here is a structure of the knee. Okay, I'm pretty sure that everyone has seen these pictures before. So what you need to understand is you know, the knee is by itself is a very secure structure. It's a very stable structure. Just tons of ligaments, just tons of meniscus, cartilages around that region that protect your knee. And so that's why knee injuries are commonly by contact. You know, you don't suddenly like walk one day and you blow out your knee. That doesn't happen. You know, you have to have contact and you have to have a really strong twisting motion when you're like a basketball player, when you go up when you go up for a dunk or a block and you come down, you know, if you twist your knee and it's like a high velocity injury, you're gonna blow out something. And usually what happens is the most common meniscus injury is a medial meniscus. And the reason why this is so, because you know, structurally, I don't think it's like I don't think it's displayed here, but I'm sure you guys have read this in anatomy classes and stuff. Medial meniscus is actually less protected by the lateral meniscus, you know, because of the surrounding structures, you know. In the lateral meniscus, you have a couple other structures, which I forgot. You know, I mean, anatomy was like so long ago, so I don't really keep up with that. So, yeah, lateral meniscus has a ton of like a couple of other structures that protect it from you know, contact sports and like injuries and like, you know, contact. And like medial meniscus is a bit more exposed, so naturally you would have more injuries in medial meniscus. I mean, that makes sense, you know. So you know, there's this transverse ligament in the knee. I mean, it's quite rare to have a like a injury to this ligament because, you know, there's no like mobile, there's no mobility between the attachment of these structures, so you naturally won't get a injury there. Yeah. Posterior cruciate ligament is also a ligament which can be implicated in injuries. It's also, you know, the same thing. You know, you have the anterior and the posterior cruciate ligament. The attachment is slightly different, but there's like different signs and symptoms you can see in these two ligaments injuries. I can show you later in videos, a couple videos. And yeah, I mean, oh yeah, and lateral and so there's lateral and medial collateral ligament. Okay, so you know these two ligaments are also, you know, one of the, you know, casualties like the of like knee injuries, because you know, usually when injuries happen in the knee, a lot of structures get damaged. You know, I wouldn't say it's rare to have like a single structure damage, but it's more common to have like multiple like structures getting damaged in knee injuries. Yep, that's just how it is. So in this clip right here, okay, I'm just gonna show you guys what this test is. So a brief overview of what this test is. So this is a Lachman test. This is a test where you know, physicians, what they do when they wanna test out whether there's any instability in the knee with regards to anterior and posterior cruciate ligaments. So this is how they do it. Okay, I'm just gonna play the video right here, and you guys just have a look. Just let me know if you guys can't hear the audio or whatever.
Lachman test.
They can hear.
The Lachman test evaluates the stability of the anterior cruciate ligament, or ACL. With one hand, grasp the distal thigh and grab the proximal lower leg with the other. The thumb should rest in the area of the tibial tuberosity, and the leg is flexed at around 20 degrees. To test the stability of the ACL, quickly pull the lower leg forward. If the patient's thigh proves to be too heavy, you can place your own thigh underneath the patient's for support. The translational forward movement tenses the ACL. Physiologically, you should feel a firm endpoint, just like you would when pulling on one end of a cord. A soft or absent endpoint, especially in comparison to the other side, indicates insufficiency of the ACL, and the Lachman test is considered positive. Additional tests to assess ACL stability include the pivot shift test and the drawer test, which are explained in separate videos.
Okay. So as you guys saw in the video, this is a Lachman test. It's one of a couple of tests they use to investigate whether there's any anterior or posterior cruciate ligaments. The other one is drawer test. We're gonna see it in the next video, but just want to let you guys know that this Lachman test is, I would say, you know, if you're used to it, it's like much easier to perform because it's much faster than the drawer test. And the fact that, you know, Lachman test is actually more sensitivity with regards to detecting injuries. So you know, the higher the sensitivity, the easier it is for you to know that this structure has been damaged. So yeah. The other one is what's it called, a drawer test. So I'm just gonna play it right here. And if you guys have any questions, just like put it in the comments, or, you know, switch on your mic and you know, figure it out.
Drawer test. The drawer test is used to assess the stability of the anterior cruciate ligament, or ACL, as well as the posterior cruciate ligament, or PCL. Place the patient's foot on the bed so the knee is bent at 90 degrees. To prevent the foot from slipping, the examiner can carefully sit on the patient's forefoot. Grasp the lower leg with both hands, with the thumbs resting on the tibial tuberosity. To test the stability of the ACL, pull the tibia forward. For the PCL, push the tibia backwards. Physiologically, tibial translation movement should be minimal in either direction. The test is considered positive if there is excessive tibial translation, particularly in comparison to the contralateral limb. Excessive anterior tibial translation indicates a lesion of the ACL, whereas posterior translation suggests a lesion of the PCL. Always start the examination with the lower leg in a neutral position to avoid false positive test results. For example, if the PCL is insufficient, the lower leg might be displaced posteriorly at the beginning of the test. Performing the anterior drawer test from this position would then result in significant anterior movement even though the ACL could be intact, and the examiner may wrongly conclude the test is positive. The gravity test is another examination to assess the stability of the PCL. The ACL can be examined by performing either the pivot shift or the Lachman test. All of these tests are demonstrated in separate videos.
Okay, and that is the drawer test. Okay, as you guys can see, is there any third year here? I'm pretty sure one's like one's right here. So is a third year like the clinical years? Is third to fourth? Is it like starting third year? You guys like go into the hospitals and stuff? Hello.
We are
Sophia.
yeah.
Okay, so for the first 2 years, you don't get to go to the hospital at all?
There are internship, but voluntarily. The school
Oh,
provided.
voluntarily. That means you guys don't go. Well, okay, I've been there, done that. Okay, so this is just another like view, a cranial view of the tibial plateau, which is the inside, which is the cross section of the knee. So you can see here, you can see the meniscus, you can see the attachments, you can see the ACL and PCLs. You can see like how they attach, like from, you know, it actually like resembles an X to give more stability instead of a, you know, like parallel. So, you know, God's design. So yeah, before we move on to the other like systems, I just want to like briefly mention like how a meniscus like appears and how injuries to like different parts of the meniscus can affect healing differently. So as you can see here, this is a cross section, a cranial view cross section of the meniscus, and you can see here like it's labeled 1, 2, 3, and you can see 1 is slightly red. No, 1 is much like a dark red, 2 is a light red, and 3 is you know, there's no red at all. And what it means is the closer it is to the periphery, the more blood supply it is, and the closer it is to the center, the less blood supply it is. So if you ever sustain a meniscus injury, and when you're doing an imaging, you can find out like which of these locations have been, you know, affected. So essentially what they do is they want to make sure you guys, and if you guys like sustain any meniscus injury, whether they want to approach it conservatively, meaning they don't do any surgery, or they want to send you for an arthroscope, which is like a surgical repair. And the reason behind this is because like if you have a meniscus injury in zone 1, you're gonna have a lot of blood vessels there, and you know, blood vessels are great. Actually, they're really great for healing because, you know, blood supply, it brings in oxygen, brings in glucose, nutrients, all which are essential for healing. And at the same time, they take away all the inflammation, the inflammatory cells, and all. Yeah, and as you move away, the further you get away from blood supply, you get less blood flow, you get less nutrients coming in, you get less of the toxic metabolites going out. So healing is going to be slower in zones where there's less blood supply. Okay, that's the idea of it. And this is what they do. It's a propeller tap. It's one of the physical examinations they do for looking if they're looking for any knee effusions. Effusions are essentially fluids that accumulate if there is any inflammation. Okay. And then this one is a McMurray test. This is just a test for them to see whether you have any meniscus injuries. Let me just play the video real quick. Cool. I guess not. So we're moving on to this one, this post right here. Got someone in the chat. I'm a third year, but not the same system, I guess. Okay, never mind. All right, so I'm pretty sure you guys have seen this. I think it's quite famous on the internet. I think I posted this, but you know, pretty sure you guys have seen this elsewhere. So fish skin. What fish is this? This is tilapia? I don't know. No idea what kind of fish this is, but you know, God bless him. So this is a picture of a burn wound getting covered in fish skin. Now this, my friends, this is not ideal. Well, it looks cool, you know, Aquaman stuff, but this is not ideal because like, you know, with like very long time advancements in medical like technology, we have like dressings, we have all sorts of dressings that are really good and really promote healing in burn wounds, and they are more far superior than whatever we have here right here, which is fish skin. Okay, I'm not sure where this picture was taken. It's probably, if I'm guessing, it's probably a third world country somewhere where they maybe ran out of wound dressings, like proper wound dressings, and they resorted to using tilapia fish skin to do this. There's a lot of pros and cons in having fish skin to like apply as a wound dressing. I mean, but the cons outweigh the pros. So, but before going to cons, I can talk to you a little bit about the pros of using fish skin. Fish skin by itself has a lot of content collagen, so that kind of promotes healing because your skin itself is like there's a collagen layer. So that's the base. That's how they argue that fish skin is actually beneficial as a wound dressing. But the cons is fish skin isn't sterile. So fish skin introduces a lot of bacteria, and because of this, if you want to use fish skin as a dressing, you have to cover the patient with antibiotics, which in itself is exposing the patient to kind of an unnecessary treatment, if you can do without the fish skin. So you in order for you to use fish skin, you gotta give the patient like antibiotics, which is like you wanna prevent the patient from developing like bacterial infections and stuff. And that's creating one problem with another problem. So you don't want that. So I mean, I'm pretty sure you guys have read in pharmacology that antibiotics, a lot of them have a lot of side effects, like adverse effects. Like you got I'm not sure whether like vancomycin is used in your country, but vancomycin has a lot of nephrotoxicity, like ototoxicity, like just a like as well as a nephrotox. Did I say nephrotoxicity? I forgot, but it causes a lot of problems if you like use it indiscriminately. And with the fact that vancomycin, a lot of antibiotics are nephrotoxic, what you're having is burns. Okay, in situations in conditions of burns, I'm not sure whether I'm talking too much like medical lingo, so if I do, you guys gotta stop me. But in terms of in conditions where patients sustain burn injuries, most of the time, like a lot of these patients are going to be leaking a lot of fluids from these injuries. So these patients essentially are in the state of hypovolemic shock, not hypovolemic shock, but hypovolemia. So the kidneys are a really essential organ in like controlling like fluid in the bodies. So if you have like a if you are in a state of hypovolemia, not like that means your kidneys is essentially not getting enough blood. So what you have here is a pre-renal acute kidney injury. Okay. And in that state, if you want to put in fish skin, you got to put in antibiotics. That creates another problem because there's a couple of like, I'm not sure whether like majority or like minority of antibiotics they are like excreted from the bodies through the renal system. But if you have like injuries to the kidneys and antibiotics, they can't like get removed from the body like by the kidneys, you're gonna have a accumulation and subsequently a toxicity. So, you know, as you can see, like using fish skin, it creates one problem, which kind of like it's like a snowball, like from rolling down from a mountain, it gets bigger and bigger and bigger. So that's why like no one uses fish skin. I mean, it looked cool for sure, but to be honest, like practically, not really. Okay, so we're done with fish skin. Just want to show you guys like a couple of slides I have here. So this is a slide of like the layers, like the degree of burns. As you can see, you guys can read it yourself. Like there's normal, first, second, third, and fourth, and the management will be different. The more serious your injury, the more the more invasive. Invasive meaning the more you need to use like sharp stuff to cut the patient up. Yeah, to manage them. Okay, this is a poor guy who went to the beach and forgot to put sunscreen. So what happened is he got sunburned. So I'm pretty sure you guys have seen this before. I'm not sure whether there's any beaches in Turkey. Are there any?
Yep, there is.
There is a beach, okay. So is there a lot of locals that go to the beach to do tans? Or is it like a Caucasian thing?
I think it happens more in the southern parts of Turkey.
Southern parts, okay.
Yeah.
But yeah, if you guys ever go to like the beach to suntan, I would suggest using a lot of skin lotion, because there's a reason why in the Western world skin cancer is the #1 cancer in the world. Yep. Use your skin lotion, guys. So this is a picture of if I remember correctly, this is a picture of a superficial partial degree burn, which is a second degree. What happened? Okay, I thought I lost you guys. Okay, so you can see the blister right here. Underneath is the fluids, like I talked about. When you have burn wounds, what happens is a lot of fluids start coming out of the body. Okay, so this is a picture of the same third, like the second degree, like superficial partial burn, but in this case you see the blisters have popped. All these stuff right here, these are all blisters, and they have popped, and the fluids have been like removed. And this poor man right here, this is a second degree burn, but it's a deep partial degree burn, meaning it's slightly, the pictures that I show right here, they're all like in sequence. So we have the most mild ones to the most severe ones. So this is like a spectrum. You can see a bunch of blisters, yeah, a bunch of blisters, leathering. And if you go into third year, you're gonna find out that there's like different signs and symptoms of these kind of burns. Like the more superficial the burn is, actually what happens is it's more painful. Because like the deeper, like the more serious the burns itself is gonna kill off the nerve endings. So although the skin looks really charred and stuff, the patient doesn't really feel pain. And the reason why is because the nerve endings that carry the pain signals are all been destroyed. So they don't actually feel that much pain, but it's pretty dangerous nonetheless. So this is a picture of a 3rd-degree burn, which you can see charred, black, like charcoal. It's dangerous because like the parts of the skin that has been charred black, it's actually like harder and very non-elastic. I mean, our skin right here is like kind of elastic, right? But in terms if a patient sustain this kind of burn injuries, their skin are gonna be like a wood. They're gonna be you can't pinch it. It's gonna be like a whole piece of wood right there, like a piece of wood. You can't like pinch it. You can't do anything, and that will cause a couple of problems down the road, which I'll show you guys later on. So this is also a very unfortunate patient. I'm not sure whether this is a patient or this is a model, but yeah, this is a 4th-degree burn. This is the deepest you can get. That means even the bones are charred. You can see right here, the bones are like exposed and stuff. Yeah, pretty gross, right?
So for this one, they have to be amputated, or they can save something.
Unfortunately, they can't save anything because
The
once you got,
necrotic, I think.
yep, you're
Mhm.
necrotic. You can, it's up to the patient whether they want to keep it, but with keeping necrotic tissues, the problem is subsequently infection. Since like these tissues are dead, they're essentially providing a nidus for infection, like bacteria and stuff. So I mean, if you have like these kind of hands and you stay sterile, you keep make sure you don't get anything on it. I mean, you could essentially live for like a quite long period of time without like having problems. But the problem is, much of the world, that much of the environment that we live in, like it's not sterile. So you're gonna introduce like bacteria like quite easily. So you're gonna essentially be inviting bacteria to come kill you. Okay, so yeah, that's why people choose to get it amputated, because they don't want to have that risk. All right. I'm gonna give you guys like a like a quick 2-minute break or like 5-minute break because I need to charge my computer. It's like low battery and stuff. So Dahlia, can you just like take over the floor, please?
Okay, of course. We can give a little break if you want.
Yeah, like a oh, you
Yeah,
guys don't want a break?
bathroom break or something.
Yeah,
Do
yeah,
you
sure. Like a
guys need
bathroom break.
Okay, okay.
Mhm.
Let's be back at 45. Okay. Are you ready?
Yeah, I mean, so
Okay.
okay, I can go on. Sure. So this is a picture of like how they estimate burn wounds in patients, and just a little bit of context on why they do this is for them to as I mentioned just now, in burn wound injuries, essentially what happens is a lot of fluids seep out of the wounds, and like seep out of wounds into the external environment. So you essentially are in a state of hypovolemia. So a lot of the principle of management of burn wounds will be fluid replacement. So you want to calculate how much fluids you want to replace in the patient. So, and you don't want to like give too much fluids, because if you give too much fluids, you're gonna cause a state of hypervolemia, which is also bad. You're gonna cause like states like you're gonna cause if your patient is hypervolemic, you're gonna cause like swellings, like in the legs. You're gonna cause swellings everywhere. You're gonna cause like pulmonary edema, which is fluid in the lungs, and you want to avoid that. You don't want to overtreat a problem, because if you overtreat a problem, it's gonna cause another problem. So as I said just now, you want like a formula for you to calculate like how much fluids you want to give. So stay with me. So this is how they calculate. This is one of the more famous ones, which is the Wallace Rule of Nines. So what you have here is a diagram, and you can see the chest is 9%, the front of the chest is 9%, back of the the chest is like another 9%. So from this diagram, you can kind of determine like how many percent of the body surface has been affected by burns, so you can adjust the fluids later on. So I'm just gonna share something before I forget. So again, I can't remember. Fluid versus inverse. Okay, I think it's this one. Yep. Okay. So yeah. Now this right here is exactly why we calculate the surface area of burn injuries, because we're trying to, calculate the amount of fluids that we want to give, and the usual formula that we use to calculate that is called the Baxter or the Partland formula. And what it does is they calculate it using this formula. It'll be easier to use like a picture instead. Yep. Okay, so this is essentially a very simplified version of the Partland formula. But with medicine is constantly changing, right? So I remember I think this year or last year they recently made modifications to the Partland formula. So instead of 4 mLs per kg per percentage per 24 hours, they actually reduced it to 2 ml. So the reason why they do this is because they have done a couple of studies, and they found out that in these kind of patients, in certain patients, the more like if they use the standard 4 ml per kg, they cause a lot of cases of hypervolemia, which is like a lot of overload of fluids in the patient, and that's bad. So what they did is they modified it. It's for specific patients. I don't think it's for every single patient, but he have to meet some criteria, and after that it's 2 instead of 4. So you can see here they calculate using the burn percentage like from the diagram that I showed just now, and they calculate the amount of fluids they want to give. And so you can see here half the amount of fluids they're going to be given in the first 8 hours from the time of the injury, and the other half, which is the rest of it, will be given in the next 16 hours of the 24 hours. So this is just something that you guys will you guys will come across when you guys like enter like third, fourth, fifth year of medicine. But essentially this is what it is. Okay. And this, my friends, is the more it's a more complicated one, but it is the gold standard. So I'm gonna. I mean, I can't see any of you right now, but I'm assuming Dwala is Dwala there.
Yes, I'm here.
Yeah. Can you just see these two diagrams, like Wallace rule 9s and the Lambrauder chart? What's the difference? Okay. So I'm going to show you the Wallace rule 9s first. Okay. I'll give you 5 seconds. Okay. Now see this one. Now, can you tell me the difference between the diagrams?
I think this one have more details because the other one just used 9% for.
Yeah, you're right. Because, burn wounds, I mean, they don't come in like complete packages. So you're going to have like little like different areas where you're burned. So this Wallace rule of 9s isn't that specific, isn't that detailed. But this Lambrauder chart is pretty detailed, right? They even like they kind of like separate these like regions into smaller ones so they can precisely find out like how many percent of the body surface area has been affected, rather than the whole arm itself at 9%. You have the whole arm broken into three segments. So you have the 2% up here in the upper arm, 1.5 in the forearm, and 1.5 in the hands as well. So that's how they are more accurate in determining the amount of fluids to give. Okay, so all right. So just now I mentioned that in third and fourth degree burns, the skin is like wood, and the reason why those injuries are really dangerous is because when you have like a circumferential, meaning like the entire skin in your extremities are like charred, what's gonna happen is the skin acts as like a tourniquet, and it's gonna constrict all the blood vessels in that arm. So it's gonna cause more injuries because you don't have blood coming in, you don't have blood going out, so you're gonna cause like ischemic injuries in the extremities or the torso. So this is a video done by the U.S. military. It's like a medical training that they do. So in the field, whenever like a combatant gets burn injuries, they know how to do this procedure, and this procedure is called escharotomy. ESCHAROTOMO. So the chart, the circumferential, the chart part that I mentioned just now is called eschar. Not sure whether it's called eschar or escar, but it is what it is. So I'm just gonna play this video right here, and you guys can see like how they do a escharotomy. Oh yeah, in medicine, if there's an otomy at the back of whatever, it usually involves like cutting with a scalpel. So yeah,
At this point, this patient is simulating the same patient that we collected and brought to the helicopter. Now he's in a higher level of care. He should have most of the same injuries that he had before. They're going to find some more injuries. For some of these guys, it's going to be the first time they see anything like this because they're not medical guys at all. So the medic and I will be kind of geeking out on medicine stuff, and we'll be trying to teach some of these non-medicine folks a little bit of what we're doing.
We need an escharotomy here. His compliance isn't good, and he's not moving a lot of air right now.
Okay.
He feels really tense in his
So
chest.
explain to me how you're going to do that.
We're going to clean the area with betadine. Then we're going to go with either a scalpel and cut anterior axillary line from just below the clavicle all the way down to the costal margins.
Okay.
And see if that affects. Do that bilaterally. If his breathing gets better, we're going to roll with that, but we might have to go one across the diaphragm.
Okay.
We're going to go until we see the subcutaneous fat, and the skin is going to separate due to the pressure.
One thing I've had to learn as a doc in a leadership role is that it's not my training. I'm leading the training, and these guys are the ones who are reaping all the benefits. You guys not being medical people, this was a high level medical things going on, okay? So we were trying to walk through it with you. Mainly, we wanted you guys to just be exposed to it. And, you know, in the future, worst case scenario, who knows, you might find yourself having to help out in this kind of setting. So at least now you've been through it once. I know this was the first for a lot of you guys, so thanks a lot for coming out. And Nick, I know you definitely got a lot out of this. Good job, good work. I'm proud of you guys. Cool.
Okay, so that was the procedure just now. Okay, so I mean, if there's any questions, again, like put it in the chat. But moving on to the next one, I think we have like a few minutes to go, so I'm just gonna wrap things up with one last case. Where am I supposed to go? Okay, yeah, sure. Yeah. Oh, hernia. Okay, I can talk about hernia. I mean, hernia's hernia. If there's a defect in the muscle covering of the intestine or something, is the intestine's gonna come out. Let's just play the video just for entertainment purposes. And their cough. Okay. So yeah, we can come back and review this later on, but yeah, I just want to show you this video of an orthopedic surgeon removing intramedullary nail. This is actually real, okay? This is not for dramatic purposes. Yeah, so just a little bit of explanation of the intramedullary nail. In orthopedics, bone's gonna be broken. When you have bones broken, you need something to hold them back. And most of the time, if it's in the femur, you would need like an external applicator or internal applicator, like a metal rod or a plate for them to hold the broken bones together so they heal properly. And as you can see, like in this picture right here, they have a couple rods and they have a couple screws. So what the screw is gonna do is what the rod is gonna do is the rod is gonna maintain the alignment of the fracture, while the screws are gonna make sure that the rods don't rotate around each other, like essentially being a drill in itself. So the screws do that, and the rod do their job. So this is basically how they how they fix bones.
There
So
is
this
any machine that can do this thing, because this can cause a refracture, like doing it like that.
What, the removal of the nail?
Yes, like if there is any machine who can do the removal, or if doing it like that can cause a refracture.
Okay. The concerns are valid, whether it will cause a refracture or not, but I don't think there's any machines on the market right now that does this, because with manual removal, which is what the doctor did just now, I think there's a very, very low incidence of refractures. That's why it isn't necessary to have a machine that does it more gently, because if you have an incidence of maybe one refracture within like a 10,000 cases of similar similar cases, like it isn't really a smart choice to invent and purchase a machine just for that cost, because like it's so rare. Like even if it's like a refracture, you just fix it again. I mean, what's so hard about it? So in medicine, yeah, in medicine, sometimes you gotta see the risk, you're gonna see the benefits, you're gonna see You gotta balance it out, you know. You gotta balance out risk and benefit. I mean, nothing's like nothing in this world's ideal. You gotta like manage like which is the lesser evil. Like just now when I mentioned, you know, the one with the tilapia skin. I mean, in cases where, you know, you don't have proper dressing, tilapia skin is probably your only choice. So, you know, go ahead and use it. But since you have other options, okay, might as well use it. And the fact that, you know, tilapia skin, you kind of expose the patients to more bacteria infections and stuff, and you gotta cover it with antibiotics. I mean, that in itself is, you know, not that great of a move, you know. And you know, the concerns of refractures are valid. I can tell you that, but you know, the incidence is too low for people to, you know, create a like a hoo-ha for it. And even if it does refracture, they're probably gonna fix it like in a similar way as well. But you know, the thing is with bone fractures and when they heal, they're really strong. You know, broken bones that have healed like from fractures are actually stronger than original bones because you might have more you have more layers of calluses, you have more layers of like bones, like new bone, like with the healing and stuff. So it's usually stronger than, you know, original bone. Okay. But that doesn't mean, you know, if you want stronger bones, you gotta fracture your bones. No. Oh yeah, and you know, I'm not sure like any of you like watch MMA, like a combat sports, but you can see that a lot of, you know, these fighters, they actually practice kicking with your shin on really like hard objects like a tree, like a pole or something. And that's what they're doing. They're creating micro fractures in the bone, in the surface of the bone, with efforts to make it harder. So when they kick opponents, they won't feel that much pain, and your opponent is gonna feel that pain. Yep, that's the concept of it. Okay, this is the last video that I'm gonna show. This is how they do an intramedullary nail. Yeah. Yep. What they do is they make a small incision in the this region is called the greater trochanter of the femur. They're gonna make an incision. After that, they're gonna insert a guide wire from you know, they're not inserting into the bone, but you know, they're gonna insert a guide wire into you know, these wait, the guide wire goes into the bone. I'm sorry. So what they do is like insert guide wire into the bone. They want to like create a you know, a drill bit, and after that they're gonna ream it with a drill, and after that they're gonna insert the nail. And essentially this is better than, you know, having just, you know, in a lot of procedures in medicine, they use guide wires because they want things to be more accurate. Yeah, you're gonna see it a lot. You're gonna see it in, you know, peritoneal dialysis. You're gonna see it in, you know, you're gonna see it in like catheterization and stuff. So, you know, pretty standard stuff. And that's how they knock. That's how they use a hammer and knock in the rods. And, you know, the screws. Oh yeah, the way that they can make sure the screws are accurately placed in the bones is they have a what's it called, an imaging intensifier. It provides like real life imaging of the bones while they're doing the drill bits, so that they don't miss the small hole in the rod. So yeah, that's essentially it for this moment. But yeah.
Are they imagining the bone with the C arm?
What?
Are they imagining the bone with the C arm?
What's a C arm?
well, a giant machine that shows X-ray. Yeah,
Can you type it in the chat because I can't really hear you that
course.
well?
of course.
C-arm. Well,
Do I know its name wrong? Maybe that's the issue.
I'm not sure because like I'm not a huge orthopedic guy, and I'm not applying to orthopedics. I mean, if I'm interested in orthopedics, I would know this, but I don't. So I'm not sure whether I really don't know what it is. What this is. I'm sorry.
It's for angiography. It's like,
C-arm.
yes, it's like a machine for angiography. It's named C-arm because of the form. It's like a C.
Oh, okay. It's a angiography, like angiography. Oh, okay. Okay, I can tell what you're talking about. So it works similar to a C-arm, imaging intensifier. So instead of like vessels, they're imaging the bone itself.
Okay, I see.
But yeah, any more questions?
If this is end of what you're gonna tell, there are
Yeah.
questions that came to the forum. I'm gonna read it to you now. Okay.
Okay. Is it possible for you to share your
Share to chat?
screen?
Okay.
Yeah, whatever. Put in the chat or something.
I'm writing them to the chat.
Okay, you can just copy and paste them. Maybe
Okay.
it makes it easier.
Okay.
Okay. Give me a second. I'll just stop sharing my screen. Okay. What tips would you give to a new doctor, current medical student that you wish you knew before? I'm guessing. Okay, so my biggest advice I can give like new doctors or medical students is, believe in yourself. You got here for a reason, and it's no fluke, and it's no fluke that you're here. So you gotta believe in yourself, and even if there's gonna be tons of times where you're gonna doubt yourself. You're gonna wonder like how the hell did I like get into medical school? So you just gotta like believe that you're there for a reason. You just gotta like keep working on whatever you're working on, and everything's gonna fall into place. Just keep working. Just it doesn't mean that you can skip out on work, but that essentially means that as long as you put in the work, things will turn out okay. I mean, sometimes it won't be great, but you won't fail or anything. So have faith. Have faith in yourself. Have faith in the training you've undergone. Yeah. Okay. So what is the importance of USMLE for those who won't go to USA? The exam itself, if you're not going to the USA, it doesn't make sense for you to take USMLEs. But as a study resource, I would say that USMLE is, I would argue that the USMLE study resources are the best in the world, and because it's a major exam for of all doctors who are in America and and beyond. So what happens is a lot of companies and a lot of great doctors, they come up with resources that help people who are studying for the USMLE. So you're gonna have like resources that have been like tried and tested with a lot of applicants with when you compare like USMLE resources to the resources like the ones in the UK or whatever, or Australia or whatever, you're gonna find out that once you master USMLEs, I'm not gonna say that you're gonna find it really easy for you to transition over to the UK or US or Australia, but you're gonna find yourself in a position where you have better understanding, and it's gonna be slightly easier for you to transition. Okay. So, what's the best method to study and take the USMLE steps? Best method of studies, I'm pretty sure everyone's gonna be different. Me personally, I use like flashcards. I didn't use much videos because at that time I didn't believe in videos that much. So that's the way I study for my steps. I mean, best method, it has to be tailored to whatever you prefer. So I think this question is one that you gotta answer yourself. So what was the hardest case you faced? Well, I just graduated medical school. So as a student, you don't really like take part in cases that much. I mean, the case is gonna be handled by the attending, by the residents, by the fellows. So I mean, you do take care of the patient a bit, but essentially you're not in the front lines. I mean, you're gonna be like a couple of lines behind the front line. So there's no hardest case that I ever faced before. I mean, once you like get in the hospital and stuff, everything's pretty much standard. You're gonna see patients like with like similar presentations everywhere. You're gonna see like asthma, COPD. You're gonna see like acute, like not acute, but like heart failure, exacerbations. You're gonna see like in ortho, you're gonna see like a lot of fractures because of a lot of like motor vehicle accidents. Yeah, everything's gonna be like bread and butter. So, as a student, I'm gonna say this: you forget about all the polycythemia vera, all the like Huntington diseases. Forget about all of those. Okay, so you're not gonna see them. You have like a 0.0001% of like seeing this in your medical school career. So focus on the bread and butter of medicine, which is your asthmas, your COPDs, your heart failure, your it's called like diabetes, hypertension, all these stuff you gotta master. Right? There's no way around it. And essentially, if you master these like basic diseases, you're gonna be ahead of a lot of people, because a lot of people, they divert their attention to all these rare things, and so they don't know like the detailed stuff of these basic diseases. And yeah, that's the thing. For the most difficult type of patients, and how did you deal with them? Well, most difficult type of patients, I wouldn't say that you're difficult, but when family members of patients are like ask a lot of questions, you gotta understand that you know these people have their loved ones like in the hospital, and like could be like fighting for their lives in the ICU or something. So they're gonna have a ton of questions, and you gotta remember that if it was you in that position, I mean, hell, I would ask a ton of questions too. I want to make sure that my loved ones is gonna be fine. I make sure that they have like everything sorted out for them. Like make sure they're being taken care of well. So you just gotta have patience. Patience will come a long way, and empathy is gonna come a long way, because you gotta put yourself in their shoes. I mean, imagine that your mom got in an accident. You're gonna be worried. I mean, emotions are inevitably gonna run high. I mean, who wouldn't? Like, if your mom like got in an accident, you're gonna be scared, you're gonna be angry, you're gonna be, of course, sad. You're gonna be, emotions gonna be high. It'll be running high. So you gotta put yourself in the patient's shoe, and don't take things personally. If a patient screams at you, don't take it personally, because they don't hate you. They're just scared. They're just scared for your mom. They're scared for your dad. They're just scared for your grandma, grandpa. So don't take it personally, and try to be professional. And you know, if they if they hurl like slurs at you, please don't hurl slurs back. You know, just understand that, you know, emotions, you know, everyone has them. If you had the chance to do USMLE again, would you do it during your medical school years or after graduation? So, you know, there's pros and cons of taking the exams in medical school and after graduation, but essentially what I did is I did it during my 3rd and 4th year of medical school. So, you know, during medical school itself, because I already studied the American syllabus, that made life kind of easier for me, like during medical school itself, because you know, you understand more, you know more, and because of that, the exams are not going to be that hard because I mean, you took a like an international like a board certification kind of like examination. So like a medical school exam, I wouldn't say it can compare to it, but you're already like essentially battle tested with like some huge international exam. So just believe in yourself. I mean, you took down USMLE, so a medical school exam isn't gonna be that hard. I mean, it's gonna be hard, but it's not. I mean, you proven yourself. That's what I want to say. But yeah. Apart from that, if you did it with if you've done it during your medical school, I mean, after graduation, you're gonna have a lot of time to do other stuff. So yeah, you're gonna have a lot of time to like relax and stuff, like, and you know, applying your own time to the residency. I mean, do your own stuff. I mean, work maybe, like travel the world maybe. I mean, it's up to you. But you know, if you don't take it during your medical school, essentially what you're gonna be doing is you're gonna be studying like, I don't know, 5-6 years of medicine, and top of that, you're gonna study another 1-2 years of USMLE. So that's like, it's like 7 or 8 years of your life just studying, and that's not fun. That's definitely not fun. But yeah, that's just how it is. I mean, um, disadvantages of taking during medical school. I mean, stress, because you'll be studying your medical school curriculum and alongside the USMLE ones. Yeah, stress, a lot of stress. After graduation, I mean, the biggest benefit is you're not going to be you're solely going to be focusing on the USMLEs instead of doing your rotations, doing your medical school like curriculums and your teaching and whatever your professor like, gives you as homework. So yeah, you're gonna be you're gonna have a much easier time studying after graduation. Yeah, but then again, can you recommend those books that help you get through the years of you've been studying at university? Okay, so there's a couple of like Bibles that they say in medicine. So in internal medicine, you're gonna be relying mostly on I'm not sure whether you guys heard of it, like a Oxford Handbook of Clinical Medicine, like a small, just like a small like booklet, like a little handheld little Bible.
Can you write that down to the chat?
Oh, okay.
Make a list
How
of
about
that.
this? How about this? I can send you a list of it in the WhatsApp, so I don't have to like, do that all now.
Okay,
So I can
okay, that's
just send
fine.
you guys the list on WhatsApp. Okay,
Okay,
sure.
thank you.
First of all, I'm not a professor. If a patient comes in with first or second degree burn, what's the first thing we should do? Well, anything whenever like when a patient comes in the emergency department, I'm just gonna like, this is kind of like clinical stuff, so I'm just gonna like briefly talk you through it. But it's just really what you're gonna do is if you want to like run a primary survey, you want to make sure the patient is stable. So what they have is this mnemonic. It's called ABCDE. A stands for the airway. So airway, you gotta make sure the patient's breathing. No, the patient has a patent airway, meaning like a proper unobstructed airway to breathe. And you're gonna make, and after that, B is breathing. You're gonna make sure the patient is breathing properly, not too slow, not too fast, and the patient is getting oxygen in. Like, no, there's no problems with their lungs getting oxygen. C, circulation, You gotta make sure the patient isn't hypovolemic, because if they are, you gotta send in an IV line. You gotta make sure the patient is like getting fluids which they lost. And for disability, you want to see whether that any burns have like caused any disabilities, like maybe like an obstructed urethra. Maybe they can't what's the word? I'm just saying, man, they can't pee. So you're gonna have like acute bladder obstruction. You know, make sure that none of that happens. And that's how you do a like first that's how they do a like a primary survey, and after that you got a secondary survey and stuff. But essentially what this all means is that you're gonna learn this stuff and like you're in the hospital, so you don't have to worry about that. What kind of studying method you use while studying pharmacology, especially when you needed to recall the knowledge? So as I said just now, flashcards work. But essentially the most important thing for you to do is do a lot of questions. You know, there's a lot of question Q banks in the market. I personally use UWorld because I'm doing the USM release, and that's the gold standard of Q banks. But apart from that, there's like pretty good Q banks like Anboss. Apart from that, you got QuestMed, Postcast, Past Medicine. Yeah, all the UK stuff. You're pretty good. I've done a couple of them. If we are planning to take the USMLE next summer, what do you advise us to start preparing for it? Well, the biggest advice I can give you, if you're planning to take a USMLE, is to think, is to dedicate yourself to it, because you know I mean, when I took the exams, I mean, I had like tons of friends and colleagues who reached out to me and told me that they want to take the USMLEs, and fast forward 3 years later, none of them took it. And the reason why is they don't dedicate themselves to it. I mean, this essentially USMLE is it's not just an exam, it's basically an exam that directly impacts your future. I mean, your career. So if you want to take it, you gotta be serious about it. I mean, there's no on the fence with USMLEs. Either you're in it or you're not. And if you're on the fence, then chances are you're not gonna be dedicated to exams, to studying. So you're not. And even if you take the exam, I mean, chances are you're not gonna make it if you don't have dedication, and that's just a fact of life. What's the best way to study medicine with great productivity? I would say flashcards. I mean, finding the way that suits you the most is the most bang for your buck, I guess. Everyone's gonna have different ways of studying. I mean, me personally, I haven't taken any notes within the last 5 years of medicine. I never written down anything. Okay, what I did is I typed them out in my computer or on my phone, and after that I just compiled them over time and just like, you know, compiled them, and after that I just read them through and stuff. Okay, did you study during semesters or only in summer holiday? Bayan, I think your question is a direct message. So possible, if it's possible, you can put in the chat. Like everyone, if you want to put questions, put in the chat. Did you study during semesters? The thing with medicine is you gotta study every day if you're gonna make it. But no, I'm just kidding. If you do it right, semester like holidays are meant to be holidays. You know, if you put in the work during your semesters and during class, there's no reason you gotta like put in the same amount of work during your holidays. You know, holidays are supposed to get you to recoup, get to relax, you know, get away from the grind. So yeah, when you're doing holidays, you know, go chill, you know, go out with your family, you know, go travel, go eat something, go to cafes, go and watch football. Okay. In which year should we start to study for USMLE? In terms of should, I think if you're serious about it, you can start it in the early like an early second year, because essentially step one is a preclinical exam. So you're gonna you're gonna have step one is a preclinical exam, so you're gonna cover pretty much most of the content in your first 2 years of medical school and more, because I'm not sure whether like a lot of medical schools in their first 2 years they cover stuff like like hereditary, some kind of disease, like what's it called? Can't even remember now. Dang. Can't remember now, but a lot of stuff they don't cover in like medical school, but they do in USMLE. So I would recommend you to take step one at the end of your second year or your third year, and step two during the end of your third year or your fourth year. Or if you want, you can take it under your like final year as well. I mean, depends, because you're gonna be learning most of it. It's gonna be relevant to you, like in medical school. Do you recommend to do the USMLEs for someone who's not thinking of going to the US? If you're thinking of taking the exam and you don't want to go to the US, what you're essentially doing is you're throwing money away. You're just going up to the bonfire. You're just like take a stack of like $1,000, like $2,000, and you're just gonna chuck it into the fire. It doesn't make sense for you to take the exams. I mean, it makes sense for you to study using USMLE materials, but it's not gonna make sense for you to take the exams. I mean, yeah. You recommend first-year students to observe the operation. Who wants to be a surgeon to observe an operation? I mean, sure. I mean, if it's interesting to you, but most of the time you're gonna be standing for long periods of time. A bunch of people are going to be surrounding the operation table, so you won't get a good view as well. So essentially what you'll be doing is you're going to be standing in a corner for 6 hours, like trying to like peek through like in between surgeons to see like the surgical field, like a glimpse of it, like a little glimpse of it. But yeah, if you get the chance to observe an operation like closer look and stuff, I mean, that's great, but you won't be learning that much. I mean, yeah, how to organize your time to study and life. Study hard when you're studying, and when you try to make time for you to relax, you can study. I mean, some people can study like all day long. Like they can study like the whole 12 hours, like 14 hours straight. But first of all, that's not healthy. And second of all, you're not gonna have much of a social life. So I mean, some people don't like social life. So I mean, to each their own. So for me personally, how I organize my time is I make sure I study hard when I'm studying, and when I chill, when I relax, I make sure. Give me a second. Huh? What? Give me a second. Yeah. But yeah. You gotta make sure that you really forget about studying when you're relaxing, when you're like reading a book, when you're going to the beach. Forget about medicine for a while. Okay. Is it much harder for IMGs to match in the US? Yeah. And the UK has a different system. It's much easier if you want to go to the UK. I mean, they have like I mean, the process is much simpler and it's less brutal than the US. I mean, the US, you have a lot of like holes, a lot of hoops you gotta jump through in order for you to match there. So yeah, much harder, I would say. Okay. I think that's end of it. Is there any more questions? If not, then
No more questions, I guess.
okay. There's some more questions. Wait, let me just check a bit.
Okay.
Your
nationality, she's asking. Yeah.
My nationality, I'm Malaysian.
Okay. So, is there any? Thanks, bro. Yeah. I would like to thank you for joining us tonight. That was a really insightful night. Thanks to you. We saw some clinical cases and etc. And it was really enjoyable for my view.
Yeah, that guys
Okay,
reap some benefits at least.
yeah, thank you so much. So Dua is gonna share her screen right now.
So that's like a certificate, a thanks certificate that we gave to all the doctors that participate in our events. So another time, thank you so much. We have a lot of fun. I learned a lot of things, like the cases, like how to the life of a med student, how it's gonna be our life in 6 years. So thank you so much.
We're gonna send this in PDF to you.
Yeah.
That's all right.
Okay.
Okay,
Sure.
if we can take a screenshot, and if all the participants open their cameras, that would be perfect. So Dua,
Yeah,
can
sure.
you take a screenshot?
Yeah,
Yes.
give me a second.
Okay, thank you.